We shall now go on to our next speaker. In this section is Dr. Anbarasu, who would be talking on angiography in neuro-ophthalmology, CTA versus MRA versus DSA, differences, pros and cons explained. He's a consultant radiologist and clinical director at the University Hospital Coventry and Warwickshire, editor of Oxford Handbook of Head and Neck Imaging, has published innumerable reviewed articles and holds honorary posts. On to you, Doctor.
Thank you very much. Can you hear me?
Yes.
Yes.
Okay. Thank you very much, Dr. Chitra Ramurthy. It's very kind of you and the iFoundation team who has asked me to speak. I'm sharing my screen. Let me just start straight away.
It's not coming.
Just a second, just scroll.
Can you just stop and share again?
Okay, so let's go on to discuss this CTA and MRA and DSA in orbital imaging. The CTA is the CT angiogram and MR angiogram and digital subtraction angiogram. What is CT angiogram? This is sort of a basic things needed for the residents and the new consultants. For a CT angio, we need an IV contrast which will be injected via peripheral vein flon. In a peripheral vein, contrast is injected using a pump with the suitable pressure, and we know how much is injected by using the flow controls per second. It takes approximately 15 seconds in a normal adult for the contrast to reach aorta after peripheral vein injection. So we know exactly when it is going to reach the aorta and therefore how it is going to reach the carotid arteries. In a patient who is old or having cardiac problem, then we have to adjust that timing. We want smart automation systems which will automatically start the scanning as soon as it reaches the artery. So fast helical CT is done at the time when the contrast is in the artery. It gives the images, and another 10-second delay. If you wait, you will start seeing the veins of the brain and internal jugular vein. So the crucial timing is to sort of scan when the contrast is actually in the artery. That is the CT angiogram. This actual helical data is modified in the workstation. It sort of automatically removes the bone overlap and gives the angio-like images. So it gives the so-called CT angiogram. The two things are there. One is we are injecting contrast. The second thing is there is radiation involved in the CT angio. And what about MR angio? And I show an example here in a patient who has got a supraorbital gyrus AV vascular malformation here on the left frontal lobe. And we can see the CT which was done and followed by a CT angio image showing this cluster of vessels on the left side, and this corresponding just a plain MR film just to show you this flow void. So this is an example of a CT angio which was done. MR angiogram MRA has got a unique quality of catching the flowing protons. So there are some sequences which will pick up only the flowing protons, and therefore it is able to get some signal from the flowing blood, and we can actually control the direction at which the flowing protons are actually gives a signal. So there is no need to inject any contrast. So you get it has got a slightly lower sensitivity and specificity compared to CT angiogram. However, it is a very great screening tool. It is usually combined with other orbital and MR brain sequences to get other additional information. Sometimes even a simple post-contrast images also gives additional information about the vascularity of lesion. But to get these images, now you are seeing an axial view of the circle of Willis. We can see all the branches, all the major branches. We can actually appreciate the internal carotid artery from the skull base and up to its branching into ACA. We can actually, on a sagittal reconstruction, we can able to see the ophthalmic artery, posterior communicating artery, and all those branches can be appreciated without even injecting a single dose of contrast. And that's the uniqueness of MRA. The DSA is done at cath lab, and the catheter is inserted in the femoral artery, reaching the arch and guided into the common carotid artery, and followed by contrast injection directly into the artery. The technology subtracts the initial pre-contrast image from the contrast image, thereby subtracting the bone and show only the vessels. And so you get the sort of name digital subtraction angiography. It is regarded as gold standard for most of the vascular lesions intraperitoneally, example like an aneurysm. It is invasive, but it allows interventional treatments like coiling or occlusion of a carotid cavernous fistula or whatever. So this is a cath lab where you will be doing that particular procedure. So this is an example of a DSA where the contrast is injected into the left internal carotid artery. We can see the branches, we can see the ACA and MCA, we can see AP and oblique views. You know, after one sort of second, we will be able to see the various branches, the MCA and ACA branches. We will be able to appreciate small aneurysms much better in this way. But what are the pathologies we can pick it up? Carotid cavernous fistulas, ophthalmic vein or cavernous sinus thrombosis, vascular malformations like arterial, venous, varix, venolymphatic malformations, capillary and cavernous hemangiomas, and other orbital masses where you need to know the vascularity. And these are the conditions where MRA, DSA, or a CT is useful. Just to show you a couple of signs which are important when you pick up these ones, are to look for superior ophthalmia, which is connected to the cavernous sinus, and therefore the engorgement or even sometimes thrombosis is very useful. Cavernous sinus engorgement, asymmetry, clot formation, increased arterial supply, increased blood vessels, tortuosity of the vessels, delayed filling, lesion enhancement. Is it an intense or severe enhancement or moderate enhancement or variable enhancement? Now, these type of points actually helps us to classify some of the lesions, particularly when it's related to various vascular malformations. An example here is a carotid cavernous fistula. This is an MR angio where we're able to see the arterial flow within the cavernous carotid region surrounding it completely. So this is a arterialization of the flow within the cavernous sinus happens in a carotid cavernous fistula. On the left side, we can actually see the very clean margins of the left internal carotid artery in the cavernous segment. Sort of, you can see the other branches as well. Another example here, patient has got a cavernous angioma on the T2-weighted MRI is hyperintense. On post-contrast T1 fat set MRI, you can actually see there is a gradual filling of the contrast into this particular lesion. And see, if you wait for about another 5-10 minutes, it will gradually fill up completely. And that's a typical appearance of a cavernous angioma in the retroorbital plane. Another example of an ACA aneurysm, which is picked up on this MR, and just a graphic just to show you this aneurysm, which is seen on the pre-contrast. But on the MR angio, you can see the surrounding thrombus and the central aneurysm. Another example here, this is a patient who presented with the right third nerve palsy. You can actually see the slightly abducted eyeball here. And this is a pre-contrast CT and the post-contrast CT. You can actually show a blob of enhancement is seen. And this patient had a CT Angiogram. We can actually see this is a classic posterior communicating artery aneurysm arising from it, and then patient went on to have coiling done. And again, a graphic appearance of a posterior communicating artery aneurysm in this particular. So in summary, the MRA is a screening tool. There is no radiation involved and there is no need for any contrast injection. It is a non-invasive technique. It takes some time to complete it. CT angio is now very commonly used because it's a non-invasive assessment and planning the treatment for confirmation of a vascular lesion. If you have queries on MRA or doubt on MRA, then CTA clarifies it. High suspicion with normal MRA, then you do a CTA. And of course, most intervention radiologists, before they do anything, before putting the catheter into the for coiling or stenting or whatever, they will have a CT angio ready so that they can actually plan to the millimeter exactly what they need to do it. So that way, CT angio is very useful. Only thing is there is radiation involved, and the contrast is need to be injected. And obviously, the benefits outweigh the risks. We do the CTA. And DSA is usually nowadays then prior to endovascular treatment and solving sometimes queries on CTA. Sometimes a blub or a blister-like aneurysms can easily be missed on MRA, picked up on CTA, sometimes very much picked up only on DSA. So this is sort of a practical plan for patients who has got a suspicious vascular lesion in relation to Orbis. Thank you very much.
Thank you very much for giving us so much clarity, Doctor. Murli, will you have a question for him?
Yes, Dr. Anbarasu, I have a question that it is said in third nerve palsy,
Yes.
if you do pick up an aneurysm in digital subtraction angiography, that was
sharing.
Sorry, please repeat it.
Yeah, it is said that in third nerve palsy, I recently heard it in one of the webinars, that in third nerve palsy, if you do pick up a aneurysm on digital subtraction angiography that was missed on CT angiography, it is rarely of any clinical significance. So is that correct for third nerve palsy, that we can stop at?
Yes, yes, in a way, yes, because there is actually a variation. There is something called infundibulum or funnel-like a variation which can occur at the origin of the posterior communicating artery, which is sometimes not seen on CTA, but often sort of picked up on the conventional angiogram. And most of the time, that normal variation can mimic like an aneurysm. And that is one second. And obviously, a small aneurysms which are aneurysm-like appearance, which is not actually pressing on the third nerve, or maybe just a simple. Usually, they are not so much significance. But generally, if there is an aneurysm in the PCOM which has got associated with the painful third nerve palsy, then most of the time, I think they end up in having some sort of a treatment.
Can thrombus aneurysms also be picked up on CT angiography because there will be no flow there? Thrombus
If
aneurysm.
that obviously thrombus aneurysm, you can safely leave it. There's nothing to be done most of the time.